It was in pre-treated population of patients, and it was independent of the pressure of TROP2. And the toxicity, it was more or less the toxicity that we are used to treat with chemotherapy. This toxicity was nausea, diarrhea, fatigue, alopecia, neutropenia. I would like to emphasize that interstitial lung disease, that is a very concerned adverse event with antibody, with sacituzumab was very low, and that's good. Even if the adverse event leading to dose reduction was 43% of the patient, almost all the adverse event was grade 1 and 2 in this phase 1/2. Of course, in this trial, we have to see the tumor response related with overall survival. Well, it's very early, but you see here in the cohort of small cell lung cancer, we know small cell lung cancer is very sensitive to chemotherapy, but it's very resistant to chemotherapy also. So whatever we find for this disease is important, and we have here an overall response rate in all the population of 14%, and in the doses 10 milligrams per kilo, 17%. Is not bad. Even if we are talking stable disease, 42% of the patients stay in stable disease. In a small cell, it is a good thing. Around 1/3 of the patient with refractory small cell lung cancer after first or second line therapy get some clinical benefit. So we have also that the toxicity in small cell cancer, it was more or less the same. It was diarrhea, nausea, fatigue, neutropenia, vomiting, and the grade 3 adverse event was generally low. As I said before, grade 1 or grade 2. And it's nice because this kind of toxicity, we are used to treat this kind of toxicity with chemotherapy.
It's important I think it's a really important point there, Dellis, because when we think about antibody-drug conjugates, these are sort of directed. We think of them as targeted agents, but they're not targeted in the sense that we traditionally think of in lung cancer. A lot of people don't realize that the side effects align much more closely with chemotherapy. And so, like you mentioned, we can anticipate, we can treat diarrhea, nausea. We've gotten pretty good at that. We just need to understand and remember that we need to do that. If we give these drugs without proper medication, proper supportive care, toxicities can be notable, but with proper pre-medications, proper support, these are much better tolerated. These are things we're very comfortable with.
That's so important. We have to insist that education to the patient, and education as we used to do with chemotherapy, but in this case, moreover, can help us very much to control the toxicity in this kind of drugs. So we have other trial. The TROPiCS-03, this is the study design. This is the use of sacituzumab at 10 milligrams per kilo. But in this trial, in pretreated population with platinum pretreated population and PD-1, but this trial is in the select elevate TROP2 population. As I said, because you are right, Stephen. TROP2 is high expressed in lung cancer, but we still need him to get very biomarker. I don't know if it's TROP2, I don't know if something else related, but we still, it's a very good trial, it's a phase 2 trial. We have the book 1, everybody are waiting for the result, we're waiting because it's a phase 3 trial in patients with non-small cell lung cancer progressing after platinum or immunotherapy without driver mutation, are randomized to sacituzumab govitecan 10 milligrams per kilo, day 1 and 8, every 3 weeks, versus docetaxel, the standard of care. We're waiting because we need in this population, we know that immunotherapy changed the landscape of lung cancer, but a lot of patients are still relapsing, still with resistance of the disease. The BOK2 study design is a little bit complicated, but it's in first line. It's a phase 2 trial that with different cohort, the cohort A and cohort B is the combination of sacituzumab, pembrolizumab. The cohort A is the combination in PD-L1 more than 50% of the patient is in first line, and the cohort B is in those patients with PD-L1 less than 50%. That we know in this population the response rate is lower. And the cohort C and D is the combination of platinum, pembrolizumab, the standard of care, plus sacituzumab that is the chemo, finally, not with pemetrexed, not with paclitaxel, but with sacituzumab, and the cohort C is non-squamous, and the cohort D is squamous histology. So we have this data. It's a little bit a spoiler. You can see all the documentation, all the result of this presentation tomorrow, I think, in this Congress. But this is the extra, and we want to share with you some aspect. And in the cohort A, in patients with PD-L1 more than 50%, the response rate was 75%. It's very high, but keep attention, the number of patients is low. And in the cohort B, in those patients with PD-L1 less than 50%, we are talking sacituzumab plus pembrolizumab without platinum, and the response rate is 44%. I just want to keep attention that the grade 3 and 4 adverse event was around 50% of the patient.
If we look at these data, so these will be presented tomorrow in the oral abstract session by your colleague from Yonsei, Byung Cho. Sun-Min, what's your take on this? I know these are just the abstract. We'll see the full data tomorrow, but your thoughts on these two cohorts with sacituzumab plus pembro frontline setting. What are your thoughts here?
Yes, Stephen. So we've had several patients enrolled in this trial at our center, and will be presented tomorrow afternoon by Dr. Cho. As for my opinion, is that efficacy is encouraging in both PD-L1 high and low patients. And given that even PD-L1 0% patients were enrolled in the PD-L1 low entity, so the response rate of 44% is encouraging. And particularly, we need more long-term data to see the durability of response and the progression-free survival and the survival data. And also the toxicity data is not confirmed yet, so we need to wait for long-term data.
Yeah, these response rates are high, I think, but we'll see what the full data set looks like and see these other data sets.
Yeah, but at least it is clear that there is a good relation we can combine. The combination work. Yeah. We have to wait, but at least it's good. It's provocative, good number of patients with response. Well, the other trial is the BOG3, the Keynote D46. It is also a phase 3 in first line with patients with PD-L1 more than 50%. And we know that the standard of care in those patients with PD-L1 more than 50% is pembrolizumab monotherapy. And this trial is very interesting because it is sacituzumab plus pembrolizumab versus pembrolizumab. It's a phase 3, and we are waiting to see if it can beat the pembrolizumab result. The other trial is Velocity Lung. It is not a combination with platinum, it's not a combination with pembro, but it's another combination with others immunotherapy. It's Zimberelimab, it's anti-PD-1 with domvanalimab, anti-TIGI. We're combining the ADC with others immunotherapy compound. I think it looks promising also. The RB is also the combination with the dual adenosine receptor antagonist that we know we have a trial presented this year in ASCO with the data in phase line. Well, we need to wait, and we want to see this result.
So there's another TROP2 antibody-drug conjugate in development for lung cancer, and that's datopotamab deruxtecan. Sun-Min, I'm going to ask you to walk us through a little bit about this structure and some of the early data we've seen with this drug in lung cancer.
Okay, so next drug is the datopotamab deruxtecan. So you can see, as you see the structure in the figure, you will see the deruxtecan derivative linked to the cleavable tetrapeptide-based linker and a humanized anti-TROP2 IgG1 monoclonal antibody. It has a DAR of 4. You can see the 4 payloads in red, and the payload with a short systemic half-life and a tumor-selective cleavable linker. So Tropion Pan-Tumor 01, this is a study design which tested the first activity and the safety of this datopotamab. So in the dose escalation trial, interestingly, they only enrolled non-small cell lung cancer in this escalation cohort. Datopotamab was tried from 0.27 milligrams per kilo to 10 milligrams per kilo every 3 weeks. MTD was established at 8 milligrams per kilo, and later on, dose expansion of non-small cell lung cancer cohorts at 3 different doses, 4, 6, and 8. The primary endpoints were MTD and safety. And if you see the anti-tumor activity of Dato-DXd in the non-small cell lung cancer cohort, you can see that across the dose levels, efficacy is consistently seen in the waterfall plot. And the median duration of response was 10.5 at 6 milligrams per kilo. And if you see the spider plot on the right bottom, you can see that all those levels achieved remarkable tumor shrinkage in the beginning. Going on to the safety, overall manageable safety profiles, and some AEs specifically to note is nausea, stomatitis, and alopecia, fatigue, vomiting. So these are typical AEs that arise from cytotoxic chemotherapy as we have experienced so far. And the serious grade 3 or higher events were noted in about 20% to 35% of patients treated. And of note, ILD, educated as drug-related, was noted in about 5% to 9%. And the tropion pan-tumor-1 also included the actionable genomic alteration harboring patients, such as EGFR and ALK. So this is a very interesting finding because after failure on osimertinib, this drug can work on these patients. So clinical activity was observed in EGFR mutant positive non-small cell lung cancer harboring exon 19 deletion, L858R mutation after failure on osimertinib. And now we know that TROPION-Lung01 is ongoing in the second line. This is to compare Dato-DXd versus the current standard of care, which is docetaxel. And the primary endpoints will be the PFS and the OS. Going on to TROPION-Lung02. So this is, as Delvis mentioned before, now they're combining pembrolizumab with Dato-DXd here. So there are 6 cohorts. They enrolled advanced non-small cell lung cancer, and they also allowed prior treated or treatment-naive patients. And cohort 1 and 2 studied the doublet combination. So Dato-DXd plus pembrolizumab at 2 different doses of Dato, 4 and 6. Cohort 3 and 4, they combined Dato-DXd plus pembrolizumab and carboplatin. Cohort 5 and 6, they combined Dato-DXd plus pembrolizumab plus cisplatin. So the primary objectives were to look at the safety and tolerability in the doublet and the triplet regimens. So as previously presented by Dr. Goto this year's ASCO, this is the efficacy of this trial. So they did not specify the efficacy according to the dose levels, but they described the efficacy in doublet and triplet combinations. So if you see that the doublet population, they showed the objective response rate of 38%, and the triplet population 49%. So the efficacy goes up when we combine chemotherapy. The duration of response was not reached at the time of cutoff. And you can see in the waterfall plot that the blue boxes represent the doublet, the red boxes represent the triplet combination. They all seem to have nice tumor shrinkage. And this is the efficacy in the first-line setting. So what about the first line? As you recall, in the sacituzumab plus pembrolizumab, here, the doublet combination showed an objective response rate of 50%, and the triplet combination had 57%. And the duration of response was pretty durable, but disease control was achieved in almost 91% in both doublet and triplet. So what about safety? So in this trial, treatment-related AEs occurring in more than 20% of patients are depicted in these bar graphs. And if we see those red boxes in triplet combination, we can note that hematologic toxicities increase a lot in the triplet therapy, such as anemia, thrombocytopenia, neutropenia. And I think these suggest that we need appropriate measures and preemptive measures maybe in the dealing with the hematologic toxicity. And also, the A's of special interest are notable. So oral mucositis, stomatitis, these are fairly common, occurring about more than 50%. And also ILD, pneumonitis, adjudicated as drug-related, occurred about 70% in doublet and 22% in doublet. And ocular surface toxicity and infusion reaction. So now we will have new data coming up tomorrow. This is a TROPION-Lung04. The study design is very complicated, so I'll let you follow tomorrow. But from cohort 1 to 4, they analyzed 2 cohorts in the abstract. So the efficacy in the first line. So the cohort 2 and 4, they show the response rate of 50% and 76% respectively, with the safety summary showing as below. So, okay, handing on to you, Stephen.
Douglas, if we look at these frontline data, what's your impression here? Again, we'll see this tomorrow at WCLC 23 oral abstract session on ADCs. Delvis, your initial impressions just from the abstract?
So Stephen, again, we are trying to move quickly to the first line, the combination with ADC and immunotherapy. And it probably will work, I'm sure of that. And you can see the result, the response rate is even higher in the cohort 4 with the combo. But again, the number of patients is low, it's a small number of patients, and we have to keep in, we have to wait to have more time to the follow-up, also to see the toxicity. Because up to now, the combination of platinum-based chemotherapy with pembrolizumab, with another, or Nivo plus EP, or the rest, can produce, we know how they work, we know after 5-year follow-up, that a lot of people are still alive and without an increase of toxicity. And here, we need to be cautious, that's what I said, but I'm happy to see that the combination work.
Yeah. These data are coming fast, and it's good to see activity. Clearly, these are active drugs, and we're adding efficacy to them. We're getting a lot of questions in there, so I'll encourage people to keep asking questions. One of the questions has to do with endpoints for these studies. I think it's very relevant to these initial results. What we're seeing now with these early readouts is response rate. And response rate can be helpful for patients that are symptomatic up front. Our question, though, long-term, is that all these drugs are doing? Are they just adding additive benefit, or are we really seeing synergy? And for that, I think we need more long-term survival. It's good to see better response rates. What we really want is longer survival. And because of the way these drugs work and interact with our immune system, because of the different mechanisms of action, there may really be a synergy which might allow us to get more durable responses too. And so those data aren't here yet. I'm surprised we've got so much data already to see, but clearly active drugs. So let's go to our poll questions here. These are the same ones we talked about before. QR code to jump in here. What is the current patient selection strategy for the more recent phase 3 studies for TROP2 targeting ADCs in lung cancer? Is it TROP2 expression by HC? Is it mutation? Is it amplification? Or is it no selection? Go ahead and key in your answer here, and we'll see if this changes over time. What we are looking at, it is no TROP2 selection for now, but it doesn't mean we've given up on finding a biomarker. We're just not convinced that TROP2 IHC is the right biomarker. So still working on that, and we'll see if other selection strategies do develop, again, with proprietary antibodies here. Let's go to this question again. What strategies are currently under investigation to integrate TROP2 ADCs into the treatment arsenal for advanced non-small cell lung cancer? Are we looking at monotherapy in a second-line setting, first line with IO therapy, or first line with chemo IO, or all of the above going forward? Go ahead and key in your answer here. And I think one thing that speaks to how quickly we've made progress is we have a whole session just on ADCs tomorrow for oral abstracts, and there's going to be even more in future congresses. And so ADCs clearly here to stay. We're seeing a lot of potential based on some of these early data. Let's take a look at our answer here. When we think of how we're using it, it is for all of the above. We're looking at all of these strategies together, the majority with the right answer here. The first studies to read out will be those second-line trials and some early data in the frontline setting too. Okay, so let's talk about practically how we integrate these. Here's a case, one of our patients, a 72-year-old male, former smoker, found to have a right middle lobe lung mass. Gets this PET scan that you see here. We've got that lung mass, we've got regional adenopathy and bone metastases. Biopsy shows squamous and adeno features, no actionable alterations. Our PD-L1's high at 70%. And so began frontline carbo-pem-pembro, a regimen that you've made famous there, Delvis, and did well initially with a partial response, but then did show progression after about 3 months in the liver. And so now we're talking about second line. After frontline chemo IO, what are our second line options? Delvis, what are you reaching for today off study in the second line setting?
Well, it's quite interesting because, you know, unfortunately, we are still seeing this kind of patient in our clinic. Even if chemo plus immunotherapy work, and we know that, a lot of them relapse and are resistant to therapy at the beginning. And the standard of care for this patient is docetaxel. It could be docetaxel plus nintedanib plus ramucirumab, as you prefer, if it's in non-squamous histology. But especially in the rapidly progressive patient, we combine with nintedanib in non-squamous in Europe. But it's a standard of care, it's docetaxel, and that's okay.
So I'm in Korea, second line here for you?
Yes, I think I agree with Delvis that outside of trial, we are still stuck with docetaxel, which has a response rate of less than 20% and highly toxic in patients. When we give them 4 to 6 cycles or above, patients experience so much toxicity from docetaxel. So I think we are still in here.
But I would say something because all of us, we know that docetaxel response rate is around 8-10%. But it was in the era before immunotherapy. We are seeing right now that those patients who receive immunotherapy before and then you treat, and it works not only for docetaxel, but also for the ADC, because maybe the response rate will be different in those phase 3 trials that we are waiting right now, comparing anti-TROP2 versus docetaxel, because all of the patients receive immunotherapy before. And we need to keep this in mind.
We do. So docetaxel is still our standard of care. We've been saying that answer for decades. See Paul Bunn here in the front. And saying second-line dosi for too long. Clearly, we need something better because not only is the response rate low, the ceiling's low, it's the toxicity. It's a tough drug.
It's true.
And we really sacrifice a lot of quality of life with some of our older cytotoxic. Is this a setting where ADCs will make an immediate impact, Sunmin?
Yes, I think so, yeah. So I think we are waiting for TROPION-Lung01 phase 3 data in the second line setting. So when we have the data published, I think we'll have the answer for that because that's comparing docetaxel versus Dato-DXd 1-to-1 in the randomized phase 3 trial data. So we'll have to see if it'll change our treatment paradigm. That study.
I think everybody wants to remove docetaxel from the
Yes.
But it's going to be more than just efficacy, all right? And so it's also going to be safety. We know the toxicity of a docetaxel. We're familiar with it. That's why we don't like giving that drug. But the ADCs have their own toxicity. And so let's go to this polling question that focuses on AEs. So we're considering sacituzumab govitecan as a treatment for a patient with metastatic lung cancer. What are we going to discuss with the patient regarding the main adverse events to be aware of with this TROP2 ADC? Is it neutropenia, diarrhea? Is it stomatitis, pneumonitis, and ocular toxicity? All of them? Or we're not sure about this. So go ahead and key in an answer here. You know, for one of our other activities, we did some polls for community oncologists in the U.S., and the understanding of what toxicities to anticipate was really poor. You know, we can combat many of the toxicities. We just need to know what to counsel patients about and how to prevent them. And so I think it really is important we spend a little time on the toxicity with these drugs. And so the answer here was all the above. It's actually not what we're looking for, though. Delvis, why don't you walk us through some of the notable toxicity with sacituzumab?
Yes, as I said before, and in the previous trial that I showed, the toxicity with sacituzumab because I have to say that I think everybody are afraid with pneumonitis when we are talking about ADC. And with the sacituzumab, this kind of toxicity is low. But you have other toxicity, gastrointestinal effect like diarrhea or neutropenia. It is high. And we have to educate the patient for this. We have to say exactly in the first week, please keep attention. If you have fever, you have to come to do a blood test, and that's all. With diarrhea also, because we need to take water, to have all the pre-medication or all the medication if the patient start with diarrhea. We have to keep hydrated, and that's for me, that's the two more important toxicity that we need to keep in mind when we will treat the patient with sacituzumab, especially those. And I would like to say that especially but we saw in the trial, in the phase 1/2 trial with sacituzumab, that those patients with UGT1 homozygote, all of them, 90% are heterozygote, but around 10% could be homozygote. And for those patients, this kind of toxicity could be higher. For all topoisomerase 1 inhibitor, I recommend it to keep in mind this, and we use it with irinotecan in the practice in colon cancer and the rest of the disease. Why not to use it and to be compulsory in this kind? For me, these two adverse events are the more important for sacituzumab, that you have to educate the patient.
So, with many of these drugs, we see some myelosuppression. We can see alopecia, important to warn patients about that. But with sacituzumab, because the payload is an active metabolite of irinotecan, we're looking more at these irinotecan toxicities, and so diarrhea, neutropenia, those are the important ones to watch for. And you mentioned earlier, ILD, less of a concern with this agent, right?
Yeah. But also, I forgot, but it's good to say, it's a less toxicity, but alopecia is also here, and vomiting. And it's some kind of toxicity, especially vomiting or nausea, that you have to, can alter the quality of life of the patient if you don't manage properly this kind of toxicity.
Now, the pneumonitis, which fortunately is a lot lower here, we do see it, not very high rates, but we do see it with the other TROP2 ADC, right, Sunmin?
Yes, that's right. So with Dato-DXd, we do see a higher incidence of pneumonitis. As we have seen before in the doublet combination, 17% all-grade pneumonitis, 22% in the triplet regimen. So if we experience pneumonitis, it's quite troublesome and quite worrisome for the patients, because even at grade 2, per guideline, we should discontinue permanently the drug. And what do we do with grade 1 asymptomatic pneumonitis? Do we just re-challenge the drug? We don't have the answer for that right now. I think that will be released this year in ESMO this year. So ILD is a notable toxicity that we have to pay attention here. And I would just suggest that this DXd payload has a higher incidence of developing ILD, but we don't know exact mechanism behind that. Who will be more likely to develop ILD, and who have the risk factors for ILD?
Yeah, the toxicities with all these antibody-drug conjugates, we got to consider the payload, which is responsible for a lot of that, but also the antibody, because that's going to localize that toxicity. And those are the on-target but off-tumor toxicities that we worry about. So it's really important we familiarize ourselves with these. They don't need to dissuade us necessarily from using these agents. We just need to know what to watch for so we can anticipate, so we can properly manage the toxicities here. And so if we go back to this polling question, and then I want to get to some of the Q&A questions here, we're considering sacituzumab as a potential treatment here. What are we going to discuss about the main AEs with this agent? Is it neutropenia, diarrhea? Is it stomatitis, pneumonitis? Or is it both of those? And if you key in your question here, we've got a lot of Q&A. We're not going to have time to get through all these, but I do want to throw a couple to our expert panelists here. So if we key in our answer here, we can go to the poll. All right, and yes, the answer really neutropenia, diarrhea, our main concern here with sacituzumab govitecan. So I encourage everyone to scan that QR code, throw questions to our panelists. They'll answer any question that's thrown up here. There's some really good questions here. First question here, Sunmin, do the TROP2 targeting ADCs show CNS activity in lung cancer?
Well, that's an interesting question. I would like to know that answer too. But I think those patients with CNS disease, in theory, we don't think that this big molecule such as ADC can penetrate the BBB. However, those patients with brain metastasis have leaky BBB, so we might expect some CNS activity in these patients. So we don't have the intracranial activity data yet, so we'll have to watch for that.
Yeah, we've seen
Yes,
irinotecan is a drug we use in CNS
Yeah,
tumors, and so the
sure.
payloads may make a difference here. But we've also seen with trastuzumab deruxtecan, again, a big molecule, so you wouldn't expect it to work, but we have seen CNS responses in breast cancer. And so I think that the jury's still out. Delvis?
Yes, I'm completely agree, but we have behind as the College to Treat Breast Cancer, because I was talking with them and I said, wait, I have some patients with anti-TROP2 and with brain mets in breast cancer and are responding also.
Yes, I heard so.
I completely agree with you that when you think in antibody, it was the same with immunotherapy at the beginning. You think in the molecular, and you think it's very big to enter in the brain, but it's not necessary that, because the payload isn't small, it's a metabolism, is very active, and the immune system is activated in some way. And I think we need to see all the data, the real data in lung cancer, but I'm confident that it will work.
This is an interesting point here. Delvis, we'll start with you. There's evidence that TROP2 expression can change over time, that in about a third of patients after treatment with chemotherapy or radiotherapy, it can alter. So they're asking, what are the potential implications of these changes in TROP2 expression after first and second line treatment? And is that going to influence where we use these?
That's a very good question, but really, there is one study that said that after chemo radiotherapy, the expression, it doesn't alter very much, Stephen. And that's great, and that's good, and that's why maybe we are still, without using TROP2 like a biomarker, but I don't think that we need to do a rare biopsy and to see the expression of TROP1 after chemotherapy or after radiotherapy, because we have data that this expression change, but not too much like in other tumor and other biomarker.
Yeah, I think we need to look at these data, but when we look at frontline, second versus later lines, it might eventually sort of tell us where these drugs wind up.
I insist that we need to find other biomarker. I don't know which one is going to be related, but we have to move in all medical oncology in the same, trying to find it.
All right, this is a great point, more of a comment, I think. Sacituzumab has a drug-antibody ratio of 8, whereas datopotamab has a drug-antibody ratio of 4, but the payload, DXd, is a more potent payload than SN38. So how do you compare these two molecules without a head-to-head? What are your thoughts here, Simin?
I think it's hard to compare just the numbers. I think if you dial up more toxicity, I don't think so. So I think that even though the datopotamab has SN38, it's more potent than the dose of the SASI.
It is true.
Yeah.
It is true. The payload is potent with the datopotamab, and the number is small. But SN38 have another particular things also when enter this small metabolism, very active also inside the cells. You know, it's difficult to compare face to face which one.
It is. I think the right answer is you can't. You can't compare them head-to-head. They're different drugs. But there are two questions here. I'll try to get to the heart of this. More of a direct question here. If both drugs are available, how are you choosing one over the other?
That's a good question. We need to see the result, the follow-up. That's what I think some mean. I don't know.
I agree.
I'm concerned about the day 8 with sacituzumab and the hematological toxicity in that day, if we have to control or not. How is the result? But we need to wait and to see the phase 3 trial that is running right now, that is close, waiting for the result. What do you think?
Yeah, I think so. Both strategies are underway, front line, second line, and we have very little evidence so far that the ADC can replace chemotherapy. So many different strategies are ongoing. So I think we'll need to wait for more durable long-term responses and the data.
Yeah, I think it's a good question. These two drugs are different, right? So they have different schedules. It's true, we'll see what the indications are, but they have different toxicity. right? And that's going to influence a lot of our treatment. And we'll see what these data look like. And we'll look at more than just response rate. Are some of them working more of an additive level, and are some working more synergistically, improving long-term outcomes? So data is still pending here. This last question, I think we're going to run out of time. Last one, though, and this is a good one. Can we use these in sequence? If you receive one, develop resistance, can you go to the other? What do you think, Sun-Min?
Well, the acquired resistance to ADC is a hot topic, and I think it needs more investigation and research. So there are many mechanisms proposed for the acquired resistance. So the target down-regulation and payload resistance, many different mechanisms of action, but we don't know yet in real patients. So we don't have the pre and post biopsy samples to compare the target levels. I think that should be done in prospective clinical trials afterwards. Yeah.
No, I'm completely agree. We don't know. The answer is we don't know.
Yeah, but maybe.
Maybe.
It depends on resistance. And if there is resistance tailored to the payload, is it tailored to the antibody? Yeah. And so in theory, possibly, but we got to do those studies. We have to do those studies. So we are out of time at the top of the hour. I'll make sure we keep everyone on schedule. Thanks everyone for joining, and thanks to our my panelists here, Dr. Delvis Rodriguez Abreu, Dr. Sun-Min Lim. Thank you for being here. Visit us at peerview.com/23trope2 to complete your post-test and evaluation. For your credit, you can download these slides for your reference and watch the event in replay shortly afterwards. So everyone, have a great WCLC 23. Thanks for joining us.
Thank you.
Thank you for joining.